Good afternoon, everybody. My name is Mayra Turner. I am from Vienna, Austria. I'm a neuroradiologist. Professor Faletti, Professor Gurzianis, thank you for the invitation, and it's my first time in Torino. I hope I will see something from the city, maybe tomorrow. My topic is non-traumatic cranial emergencies. So the list of intracranial emergencies is very long. It starts with stroke, which we are all afraid of, and then goes to brain tumors, which sometimes will cause brain herniation. So how should we look at the intracranial emergencies? I have decided this time to make 3 boxes of diseases and to look at the emergencies from a clinical point of view. So we have 3 boxes: acute focal neurological deficit with diseases that will cause that one. Then we will look at the worst headache of life and what could be the cause of that. And finally, situations where we have acute or increasing confusion. Okay. If we start with the first box of acute focal neurological deficit, then certainly the most common emergency and something that you really don't want to miss is acute occlusion of an intra-arterial vessel. So means acute stroke. Central concept in treating patients with acute stroke is the existence of potentially salvageable tissue, which means the goal of imaging is to diagnose the precise type of stroke so that appropriate management can be promptly implemented. What we have to do as an imager, we have to diagnose which type of stroke it is, and what we basically have to know is which vessel is occluded if anything can be really done. You can do stroke imaging with CT or with MRI. I guess most of you will do this with acute CT. So CT and MRI are excellent methods in evaluation of acute stroke. What we do, we have 3 possibilities. We have 3 possibilities. We have parenchymal imaging, we have vascular imaging, and perfusion studies. All 3 of them will give you different information. Parenchymal image will show you the extent of ischemia, either with CT or with diffusion. Vascular image will show you which vessel is occluded, means of CTA or MRA. And finally, perfusion studies, regardless if you use CT perfusion or MR perfusion, will show you how is the collateral flow. So we will first start with the very basic things, and this is what majority of you are certainly doing. So the CT early signs of ischemia are hypodensity, blurred basal ganglia or obscuration of lentiform nucleus, dense MCA sign, insular ribbon sign, and loss of sulcal effacement. Let me show you the first case of a hypodensity on a CT. Sometimes it's pretty easy. You really see that this is hypodense area in the brain on the right side, which is ill-defined, and you don't see enough sulci on that side. But it's not always like this. Sometimes you will have difficulties, especially if you are tired and if this CT scan is made in the middle of the night. When you look now carefully, you will see that there is a hypodensity in the insular region on the right side. If you are uncertain if something is hypodense or not, then the best thing is to play with the window setting and maybe make a window a little bit harder and go far away from the image, maybe 1 meter, and then you look at it again, and then you are maybe more certain if this is hypodensity or not. Insular ribbon sign is another very important early CT sign of a middle cerebral artery occlusion. It means you will see hypodensity of the insular cortex. Why is this a very sensitive sign? So insular cortex is the region of the brain most distant from potential collateral circulation. So this will be on the left side. You will see well-defined hypodensity of the insular cortex and very, very ill-defined and very subtle finding on this right slide. Blurred basal ganglia means that you don't really see the borders between the basal ganglia, or you see hypodensity in this region, like in this particular case. It's also an early sign of a middle cerebral artery infarction. Dense MCA sign, the most famous sign for early infarction, you will see hyperdensity of the middle cerebral artery, like in these 3 cases, either distal branches or proximal, and it actually means you see the thrombus in the middle cerebral artery. If you're uncertain about that, which you also could be in an older patient, have a very calcified vessels, you of course proceed immediately to CTA, and you can be sure if this vessel is occluded or if this was only calcification of the vessel. This is a possibility to see acute ischemia with CT. should we do MR, and why aren't we doing MR all the time? The best sequence for detecting ischemia in an MR is certainly diffusion-weighted image. What do we see on diffusion-weighted image? Basically, in stroke, we have accumulation of intracellular water. We have a cytotoxic edema. We have disruption of high-energy metabolism. And what it really means, we have a swelling of neurons and glial cells. So the neurons will be swollen. So if you look at the movement of water molecules between these swollen neurons, they certainly will be decreased. So that's what we have actually restricted diffusion in acute ischemia. So diffusion-weighted image is our best sequence for detection of ischemia. It's sensitive to restrictions of Brownian motion of extracellular water due to cytotoxic edema. You will tell me, if you know how to read CT in acute setting, why should I do MRI, and how good diffusion really is? Or is diffusion really much better than acute CT if somebody is reading who is having a great experience? Well, let me show you this case. If you look at this again, and if it's the middle of the day, you will probably not have difficulties to see that this part has a slight hypodensity and you don't really see the sulci. If you're unexperienced, or if this is in the middle of the night, you might have certain difficulties. If you do diffusion-weighted image in few seconds, you will have image like this one. So it will be pretty clear that this high signal intensity on diffusion and low ADC is acute ischemia. If you then add perfusion and MR angiography, you have all your answers. Here we have acute middle cerebral artery infarction on the right side with hypoperfusion of this perfusion map and occlusion of the middle cerebral artery on that side. Now you have situations like this, which is not really sure what are you looking at. Stroke is a very clinical term. So you have this T2 weighted image, usually FLAIR or T2 will be done first. If you carefully look at this one, if you look first, you don't see anything. But then if you carefully look, you see little black dots you will see on the left side, which means vessels, flow voids and vessels, which are completely missing on the right side. Well, it's going to be tough based only on this, but then you do diffusion, you see bright signal in the middle cerebral artery on the right side, low ADC, you do perfusion, this is a MTT map, and then you do MR angiography, which clearly shows you occlusion of the middle cerebral artery. So basically, there is a lot of confusion which map you're looking at. Let's make it very simple. If you have a thrombus that occludes one vessel, you will have a certain areas in the brain around these occluded vessels. And these areas of the brain will have very different meanings. So the first one is this one of infarction. That's ischemic score, or that's dead brain tissue. That is really dead and you cannot solve anymore. And this is represented by low cerebral blood volume. So dead brain tissue has a low cerebral blood volume. The next area around the ischemic core will be tissue at risk, or something that's called penumbra, that you also all know. This part is potentially dead, but not yet. So this will be represented by low cerebral blood flow. And then finally, you have a region around it at the periphery, which is a region of benign oligemia. So this is dead, and this is not at risk. But if you look at the map, perfusion map, mean transit time, then mean transit time includes all of this. So means that cerebral blood volume will show you just dead brain tissue, then flow, which will include tissue at risk, and then mean TT, which will include benign oligemia. So this is something to remember, and it's easy actually. We have the 4 P's of acute stroke imaging. Very simple. Means parenchyma, pipes, perfusion, and penumbra. Parenchyma means brain parenchyma. You look what is dead and what is not dead. Pipes means vessels. Then you look at perfusion, how is the collateral flow, and then you're trying to see if we have penumbra. Whatever protocol you use, either CT or MRI, whatever you have in your institution, if you go over these 4 P's and 3 basic questions, you will be able to answer the question. You do CT protocol. With a non-enhanced CT, you answer the question if there is hemorrhage or hypodensity. With a CTA, you answer the question, is there a large vessel thrombus? And finally, with CT perfusion, you answer if there is penumbra and tissue at risk. If you do MR protocol, the same, maybe timing is just a little bit longer. Again, with all these sequences, you answer the same 3 questions. So whatever you do, CT of MR or MR in acute stroke setting, the important thing is that you answer all 3 questions. This is maybe simplified approach to stroke imaging based on first 3 hours and after 3 hours. For the first 3 hours, the majority of strokologists will agree that you will need non-enhanced CT and CTA. And after 3 hours, or very young patients, you would go with advanced CT with perfusion and advanced MRI techniques, because we know that also these patients will maybe benefit from thrombolytic therapy. So that was stroke. This is another patient which came in a comatose status. If you look again briefly, you might say, oh, that's okay. It's certainly not okay. If you look at this, if I can zoom this image for you, then you will see that this basilar artery is certainly hyperdense, which is not good at all. And if you would look more carefully then and go further back from this image, then you will see there is a certain difference in occipital area with hypodensity on the left side. This patient was brought immediately to MRI, which now you definitely see that there is already cytotoxic edema on the left side, and on this MRI you don't see basilar artery. So I think there is no discussion what it was, and this is the next day, with extensive infarcted areas in the posterior fossa and midbrain. This was a typical case, or a case that was pretty easy to diagnose, of a basilar artery obstruction. They are not always looking like that. Sometimes they're very subtle, and sometimes the piece of a basilar artery that is obstructed is relatively small. If you again look at this case that I will show you, then it's really tough to say if something is wrong with this basilar artery. And if you're in doubt, never hesitate to proceed to CTA. Either it's nothing or it's something. If you see this, you definitely see a feeling defect in a tip of a basilar artery, which was the hyperdense part on this non-enhanced CT scan. These patients were brought for thrombolysis therapy. Unfortunately, part of the cerebellum was infarcted, which you will see on CT and then on this diffusion-weighted image. But still, you will see that therapy was successful and patient did not remain with severe neurological deficit, just mild deficit. Now, you see a feeling defect, and now you definitely see nice and patterned basilar artery. So think of a basilar artery thrombosis if you have a hyperdense basilar artery, even if it's just a little dot on non-enhanced CT scan, especially in a patient with severe neurological deficit. Look at CTA, you will have a basilar artery feeling defects, and then do MRI for infarcted area to see restricted diffusion. Not only arteries could be occluded. We have now seen a major artery of the circulus villisi. We can now see an occlusion of basilar artery. And now, one of the possibilities to have acute neurological deficit is to have occlusion of the venous structure, either a venous sinus or cortical veins. So how is it looking like neurologically? Well, these patients present with headache in 90% of the cases, nausea, vomiting. It could almost look like meningitis. They have neurological deficit, and 50% of them will progress to venous infarction. In which patient group, or which are the patients at risk for dural sinus thrombosis? Pregnancy, oral contraceptives, hypercoagulopathic state, patient with vasculitis, don't forget this one, collagen vascular disorders, patients under drugs, or children in mastoiditis. What is happening in dural sinus thrombosis pathophysiologically? You have a thrombus in a dural sinus. Then this clot usually moves into a cortical vein. Then all of a sudden, venous drainage is obstructed. Venous pressure would start increasing. Then you will have a vasogenic edema. Finally, you have hemorrhage and extravasation, and then a venous infarct. That's why venous infarct is commonly hemorrhagic. One of the old signs that I'm sure that you all know about from a CT era is an empty delta sign, or replacement of MRI flow void sign. So usually on enhanced CT scan, you will have an empty delta, which non-filling of the thrombosed dural sinus, or on MRI, instead the sinus to be very dark, it will be bright. Remember that in venous sinuses, there is still enough flow to produce actually a flow void on this image. This would be such a case. When you look at this coronal T2, you immediately see something is wrong with the superior sagittal sinus. It does not have a normal flow void. Then you give contrast, and then you definitely see the empty delta sign in this superior sagittal sinus thrombosis. Of course, you can confirm it with MR venography if you are missing the sinus, like in this particular case. Another sign, the empty delta sign, is called dense clot sign. This is something else. This is on non-enhanced CT, when you will see hyperdensity of this sinus, which unfortunately is a good sign, but only present in 1/3 of the cases. Depending in which stage of thrombosis you are, the picture on MR or signal intensity will be different. This is a very hyper-intense sinus on T1 in a subacute stage, when the clot will be hyper-intense on T1 weighted image. This is a case of a sinus thrombosis with associated venous infarction. Not every sinus thrombosis will proceed to venous infarction. But if it does, you will have something like this: hyperintensity on the right side, hyperintense on diffusion. Then you see on this coronal T2 absent flow void, the sinus is actually hyperintense on T1, means in a subacute stage, and this is also then confirmed with this MR angiography. So again, if the patient is on oral contraceptive, if this patient is pregnant or after pregnancy, and the patients present with nausea and vomiting without a history of head trauma, has neurological deficits, maybe even seizures, then think of a sinus or look for sinus thrombosis and do the sinus thrombosis protocol, which would include axial flare, diffusion, coronal T1 and T2, some T2 star sequence, and of course, venous angiography. So key points in a dural sinus thrombosis will be delta sign, CT or MRI, hyperintense sinus on non-enhanced CT, hyperdense, absent flow on MR venography, and blooming effect on T2 star gradient echo. This was a very unfortunate patient. This was a child 4 years of age. You will definitely don't want to miss something like this. This initial CT scan was read normal. This was in the middle of the night. Maybe normal because it was bilateral hypodensity. If something is bilateral in the brain, usually it appears like it would be normal. We are always looking for asymmetry. But still, even if you miss this even if you miss this hypodensity of a thalamic region, you shouldn't miss this hypodensity of the midbrain. It's definitely too hypodense. This is 1 day later after the first scan was read negative. Now you definitely see that something is wrong in this 4-year-old child with a hypodensity, prominent hypodensity of the basal ganglia, and also you don't see basal cistern anymore. This child was then brought into MRI. Now you see even more, exactly the same actually what you should have seen already on a CT scan, bilateral signal intensity changes and hemorrhagic changes in the midbrain and basal ganglia. And of course, this was a vascular image after that. So this is a very severe case of a deep cerebral venous thrombosis, and you definitely don't want to miss this. This child died. So means deep cerebral venous thrombosis is emergency due to occlusion of the deep cerebral veins. That we mean internal cerebral vein, vein of Galen, and straight sinus. The clue imaging finding is bithalamic hypodensity. It goes even further into deep gray metanuclei, internal capsule, and midbrain. This is something that I took out from this, I'm sure that you know this site. It's a radiology assistant from Netherlands, very nice, and had this beautiful image of a hyper-intense internal vein in a case of thrombosis. So think of this. If you have a bilateral hypodensities in thalamus region, go straight to the midline and look for thrombosis of these veins. This was occlusion of vessels, and something that we all know, it's everyday life for all of us. Worst headache of life. Right. The first thing that you want to exclude is a subarachnoid hemorrhage, then meningitis, or it's maybe just a migraine. What you want to exclude is definitely aneurysm, right? If I tell you worst headache of life, and it's a young patient, then you think of subarachnoid hemorrhage, and then you think of aneurysm. So even starting on a basic T2 sequence, you would start looking for aneurysm, then you do, of course, MR angiography, and then you prove, or you find one, or you don't. So rupture of an intracranial aneurysm is the most common cause, of course, of non-traumatic subarachnoid hemorrhage. Mortality or morbidity is still very high, and the risk of rupture, but unruptured aneurysm is 1 to 2% per year. Other possibility, if you have a non-traumatic subarachnoid hemorrhage, will be if a hemorrhage due to arteriovenous malformation. There are several types of congenital vascular malformation, but you know not all of them will acutely bleed. Certainly not DVA or capillary telangiectasia. So this would be a case. Why should you think of this? This is not a subarachnoid hemorrhage. This is actually intraparenchymal hemorrhage. Now, it's very easy to say, let's proceed immediately to vessels, which you should do, but if you look carefully, and if you want to be really a good radiologist, you see that there is a little hyperdensity associated to this hemorrhage. And if I show you this, then you will retrospectively even more see the hyperdensity associated to this intraparenchymal hemorrhage. And this was, of course, proven big AVM. I don't think that there is much to be said. You just have to think about it. Once you see big vessels like this, the diagnosis is clear and you have made the diagnosis right. So one possibility of this worst headache of life would be bleeding subarachnoid due to aneurysm or AVM. And the other possibility is to have acute meningitis. And this is certainly something that nobody really likes. Meningitis, diagnosis of meningitis is pretty difficult based on imaging. Etiology will depend if you are talking about children, adults, or if we are dealing with immune-compromised patient. Imaging findings are very non-specific. Again, you will have to think about it to really realize this is meningitis. I will show you these MR imaging findings in a second. This is a normal situation. Worst headache of life. The patient is 25. He's coming from emergency unit. You do non-enhanced CT, you don't see much. The only thing that maybe you should think of is why are you not seeing at least one sulci? You should see subarachnoid spaces, even if a patient is very young. Then you give contrast agent, and now we can discuss for 30 minutes, is this leptomeningeal enhancement or not? If you have a very early meningitis or viral meningitis, you will not see a lot of enhancement. So don't expect enhancement as a sign of meningitis. Look for indirect signs. An indirect sign is a non-existent or not visible subarachnoid spaces. I personally like to do MRI if the question is acute meningitis, because it will give me much more information in a shorter time. The best sequence for acute meningitis will be flare sequence. So on a flare sequence, CSF is actually suppressed. So CSF should be dark in the ventricle and outside. If you look at this one, CSF is very dark in the ventricle, but it's bright outside in subarachnoid spaces. So that's definitely abnormal. And in cases when you additionally see small infarcts, then you have a diagnosis of acute meningitis. So your first sequence will be flare, and then you look for little infarcts. This would be also a case of acute meningitis where you slowly come to your diagnosis. First, you look at the flare image, normal CSF in the ventricles. Then you go outside to the subarachnoid spaces. Then subarachnoid spaces are bright. This is not normal. Then you see additional subdural effusion, very indicative of something of a meningitis. And then you give contrast, and then you look at the spaces. Now you have to play even more. If you do just a normal T1 with contrast, you might not see anything like this one. So you better do something with FET suppression or magnetization transfer contrast. You have to increase your contrast. Then you might see leptomeningeal enhancement, especially in the vermis region. So next time, if somebody is asking if there is leptomeningeal enhancement in the case of meningitis, go right there and look at the vermis region if you see an enhancement. If you see hydrocephalus like this, and the patient is having worst headache of life and the whole clinical picture, then again, you don't see really meningeal enhancement, but you will suggest meningitis. This is a case when you have a meningitis with ventriculitis, means, again, you have a bright subarachnoid spaces on flare, and you have this fluid level, or it's called debris level. This is already indirect sign of ventriculitis associated with this meningitis. So key points for meningitis would be Flare is your most important sequence for detection of meningitis. Complications are much more common than you suspect, or will give you actually indirect clue that we are talking about meningitis, and your major differential diagnosis will be either subarachnoid hemorrhage or carcinomatous meningitis. If we talk about the third box, acute or increasing confusion, then the list is long and I don't have time to show you all of them. But one thing I will show you, and this is acute encephalitis. And if somebody said to you acute encephalitis, then I'm sure 90% of you will immediately think herpes encephalitis. Just to remind you, there is herpes 1 and herpes 2. Herpes 1 in adults and children, and 2 in neonates. And then the whole list of viruses that actually belong to herpes virus family. What you don't want to miss is herpes simplex virus type 1 encephalitis. Remember, mortality rate is 50–70% today. So you are the first line person in this situation. You have to diagnose herpes encephalitis. Let me show you how. Herpes encephalitis is a hemorrhagic necrotizing encephalitis of old brain. Brain can be divided into old and new brain. So herpes is attacking just old brain. And what I'm thinking, old brain is actually hippocampus, insular cortex, cingulate gyrus. Exactly showed at this one. So it affects the limbic system. Basal ganglia will usually be spared, and rarely you will have midbrain and pons. The best sequence to diagnose acute herpes encephalitis is diffusion weighted image. So if there is a question of herpes, your first sequence to look at is diffusion. It will show you restricted diffusion, which will not be as bright as ischemia. It will be like white outlining of the cortex. Herpes is affecting the cortex. This would be this case, which was also shown this one. It's not difficult to diagnose herpes in a case that is so extensive as the first one. But look at this one. That's maybe a little bit more difficult. You see subtle difference in intensity of the hippocampus with a little bit brighter signal on the left side and also dorsal thalamus. If you do diffusion, you are pretty sure you see it's slight increase in signal. It's restricted diffusion in acute herpes encephalitis. So you will think of a herpes encephalitis if a patient comes with seizures or comatose state from emergency room. If you see signal intensity that affects the old cortex or the limbic system, enhancement will not be present at the beginning. You will look at diffusion for the early diagnosis, and you will not listen completely to the clinicians, even if they tell you that PCR for herpes is negative. You will report what you see, because we have certain percent of cases where PCR for herpes is negative. I always say the image is not lying. Another emergency talking from encephalitis further would be brain abscess. This is also an emergency that you have to diagnose and you don't want to miss. Brain abscess has a typical picture on MR. It has a T2 hypointense capsule with 3 layers. It has a hyperintense purulent center. It has a huge perifocal edema and ring-like enhancement. That's not a big deal. That you will know. What you have to distinguish in acute situation is, are we dealing with abscess or necrotic tumor? Because the therapy will be very, very different. An abscess goes to neurosurgical department for aspiration, and a tumor we will do something else, maybe give some cortisone or look for some other thing. So how do you do that? The best thing in acute situation is to use diffusion. It costs you less than a minute and they will give you an answer. Why is it possible to differentiate between abscess or necrotic tumor on diffusion? It's very simple. Abscess is a cavity filled with a high viscosity pus or inflammatory cells. Between all these cells, water molecules will not be able to move in this high viscosity content. In a necrotic tumor, let's say metastasis, you don't have much tissue, you have low viscosity, you have a little bit of hemorrhagic cells, and water molecules would move more freely. To make it so, this is a classical brain abscess. There is no discussion what this is with this diffusion. Very bright on diffusion, very low on ADC. These two lesions look the same. One is abscess, as I said, and one is tumor. Based on conventional imaging, in acute situation, you can't really tell. If you do diffusion, I will show you this one is bright and dark in abscess, and this one is metastasis in dark and bright, exactly the opposite. So you will use diffusion in acute situation to distinguish abscess from tumor. If you really like neuroradiology and all these long protocols, you might add perfusion, which will be negative or very tiny capsule, and then you will have even more security. What are you talking about? Abscess with bright diffusion, low perfusion, tumor with low diffusion, and a high perfusion in a tumor part. And finally, I hope I have time. I will speed up. The last thing that I want to show you, and you know, if you like what you are doing, you would want to show everything and all the diseases. So I'm trying to do my best to show you at least one metabolic acute disease, because it makes a difference. And again, you don't want to be the one who is missing PRES. PRES means posterior reversible encephalopathy syndrome. Was introduced actually 1996. And you will have patients with abrupt elevation of blood pressure, patient with renal decompensation, or immune suppressed patient, or usually patients around pregnancy or delivery. It will look like this. This was a 70-year-old lady who got allergic to strawberry. I don't know how she survived not eating strawberries. And she came one night, and this was acute CT. Bilateral hypodensities, usually located more prominent in a posterior part of the brain. That's the name, posterior leukoencephalopathy syndrome. What is happening actually in PRES, and why I'm telling you that it's important to diagnose this? Well, the point is you have a breakthrough of somehow cerebral autoregulation. You have a leakage of fluid out of cells into interstitium. So you basically have vasogenic edema, something benign. That's why it's called reversible. So this will reverse if you diagnose this. But if you miss PRES and you don't think about this, then these things will start getting into ischemia. That's why it's important to diagnose PRES early. This is PRES diagnosed very early. Bilateral changes with elevated diffusion means nothing on a trace diffuse and high diffusivity. This is PRES diagnosed too late, when we already have a cytotoxic edema and changes. This patient will definitely have changes in affected brain area. So this was a bit too late. We know that PRES can be located, the lesion, not only posterior, but also anteriorly. So the idea is now, if it's not only posteriorly, let's cut this and call this reversible encephalopathy syndrome, or RES. But if we know that it's actually not always reversible, then we will have to cut also reversible and call this encephalopathy syndrome. So out of PRES, nothing would be left. We will only have EIS, which is definitely not enough. So I think with time, we will have to have new name, or we just call it PRES regardless where it's located. I hope I was able to show you something out of these boxes of emergencies. There are many of them, like dissection, brain hemorrhage, mass lesions, but we will have to do it another time. Thank you very much for your attention.